Cape Town. We've got a very exciting lineup this afternoon. Our first speaker, as usual, will focus on the epidemiology of COVID-19 in the Western Cape. And today we've got a new speaker in that slot, who is Muzammil Ismail. Muzammil is a registrar in public health at the University of Cape Town, and will be giving us the COVID-19 update in the Western Cape, as well as discussing the new COVID-19 dashboard that has been developed by the Western Cape Department of Health. So we're very excited to hear Muzammil speaking in this slot. So over to you, Muzammil. You just have to unmute when you're given that option. There.
Here we go. Good afternoon. Can I just confirm if you can hear me?
We can hear you, and it's just going to be a matter of sharing the screen.
Perfect. Can I share screen now?
Yeah. Okay, we're seeing that. Yeah, it's on full screen mode. That's fine.
Perfect. Thanks so much, Prof. So good afternoon, colleagues. Thanks so much for the opportunity to present this afternoon. And basically, I'm going to be giving just an update on the COVID-19 epidemiology in the Western Cape, as well as some new features that we've developed on our internal as well as on our external dashboards. Just in terms of what I'm going to be covering, I'll start off with just a national perspective and overview. We'll then look at some provincial epidemic comparisons with our neighbor provinces. We'll then hone in on the Western Cape epidemic, some of the new surveillance tools that we've got in the Western Cape, and I'll end up with just the public Western Cape COVID-19 dashboard that we've updated and launched this morning. So just to start off with, I'll start off with the excess death report that comes from the South African Medical Research Council. And an interesting finding has emerged in the latest report. We're seeing an uptick in national causes of deaths in the age category of 1 to 59 in the adult population, essentially. And this is quite concerning, considering the last time that we were at this point where we were approaching the upper prediction bound of expected deaths during this period of the year was when we were entering the second wave. We can then dive deeper into understanding or looking at where these excess deaths may be coming from. So we looked at COVID-19 cases initially first, and what we see is that the Free State in the Northern Cape has seen quite clear increases in the number of COVID-19 cases over the last couple of weeks. Also, the other two provinces on the right-hand side, the Northwest as well as Gauteng, has been noted to show some mild or some moderate increases in cases more recently. They're not as stark as the Free State in the Northern Cape, but they are certainly, particularly Gauteng in the last week, has risen above the sort of endemic state in the interwave period. The Northern Cape is of interest to us because it is our northern border. I mean, the population size is quite small, so that does need to be kept in mind. But we are concerned about transmission across the provincial border, both on the west coast as well as in the central Kulu in Beaufort West. What we can do also is just to overlay the excess deaths for the Northern Cape as well as for the Free State, and see if it's actually matching what we are seeing in terms of COVID-19 cases. And interestingly, it actually does. So you can see the excess deaths over the last couple of weeks in the Northern Cape actually tracking quite nicely against the cases. The Free State also sees similar patterns as well. When we're looking at the Northwest as well as Gauteng, we see a similar type of pattern emerging as well. It's obviously a lot earlier in its pattern, but there is definitely an increase both in the excess deaths as well as in the cases that's showing itself up. When we look at the sort of the same data sources and looking at it in the Western Cape, we don't see that same picture emerging for the Western Cape. We don't see an increase in the total number of cases, and we don't see an increase beyond the upper prediction bound of excess deaths expected for this time of the year. We also monitor our reproductive number, of course, based on a 7-day moving average of cases. And in the Western Cape, we've been hovering around the 1 level for quite some time now. But more recently, we have been sitting above the 1 level. So this is concerning, and we do need to keep an eye on this. Looking at the South African Medical Research Council on the City of Cape Town wastewater early warning system, we can see that a number of the drainage areas are actually not showing any increase in SARS-CoV-2 RNA. But there is one particular drainage area, and that's the Mitchell's Plain area, that has seen a noticeable increase over the last week. And in fact, it's actually seen the highest value to date in 2021. The important thing, I think, when we were coming off our second wave is to learn lesson as to when we shift from a containment to a mitigation paradigm. And what are the trigger points, and can we be clear with regards to those trigger points when we're shifting from an endemic state to a resurgence? And what indicators can we actually operationalize in order to identify these shifts? So we've been doing quite a bit of work in terms of enhancing our internal dashboards to be able to identify this. We've been historically using 4 main indicators, and that's really looking at new cases over time, smoothed over, of course, by 7-day and 14-day moving averages, looking at positivity, new admissions, and deaths. Importantly, just based on these indicators, we have seen a peaking of overall test positivity just above the 5% mark. We were tracking more below that not too long ago. This is one of the new indicators that we've introduced, one of a few, and it's based on the IMT criteria, the national IMT criteria that looks at, and it's quite a sensitive marker, that looks at the change in 7-day moving average, the week-on-week percent increase in new cases, in new admissions, as well as in deaths. And what's interesting to note, so the importance here is that we can get a clear alert level, which is when we see an increase of more than 10% week on week, and a resurgence level of more than 20% week on week increases. Unfortunately, these indicators are quite sensitive to public holiday. It's sensitive to testing patterns and testing changes. So what one would need to look for is actually a sustained increase above these levels to be able to identify it as a resurgence. We've applied the same criteria and the same approach to positivity. And what's interesting is that we now see positivity entering an area of alert for the last couple of days. And this is a week-on-week increase in percent positivity. The concern is also that we are comparing now recently a short week, in other words, a week with a public holiday versus the previous week with a full week of testing. So we actually might be underestimating the true increase in this test positivity and in these new cases. We can monitor this obviously at a lower level, at the district level as well, but the smaller numbers does tend to make these indicators a little bit more erratic. An interesting indicator, and these are the last 2 that I'm going to be talking about, is the week-on-week percent change in terms of current active COVID-19 admissions. And what it provides us is actually a really sensitive marker for increase in terms of the service burden with regards to COVID-19 admissions. We saw increases, and what's really nice about the indicators is that it actually provides you a consistent increase over time. So when we're looking at retrospectively at the second wave, we actually see that this indicator was starting to increase in positive territory at the end of October and the beginning of November. For the second wave, and then it trended consistently until it hit the alert level in the middle of November, and then it continued thereafter. If you look more recently, over the last week and a half, we've actually entered for the first time positive territory when it comes to week-on-week increase in current hospital admissions for COVID-19. It hasn't consistently remained this way. So we are keeping an eye on this to see if it actually consistently increases beyond that point. Looking deeper at which sector is actually contributing to it, it seems to be that the private sector hospitalizations are actually one of the key drivers of this week-on-week increase in current hospitalizations. Lastly, we applied the same metric for current active cases, but we don't see any clear signs of week-on-week percent increases in terms of this indicator as yet. So just in summary, in terms of the trigger points, we're keeping an eye on a number of indicators within our internal space with regards to increases in new cases, percent positivity. Unfortunately, new admissions and deaths, they seem to be more of a lagging indicator. But what's really interesting is the current hospitalizations and current active cases, and keeping an eye on that for consistent increases. If we were to go back and actually reflect on these indicators in wave 2, from the time of trigger to peak, we actually saw approximately a 6-week period, and that gives us an indication and an idea of how much time we have to plan by actually applying some of these indicators. The last thing perhaps just to talk about and just to mention is that we have been maintaining a Western Cape COVID-19 public dashboard, and it's really about sharing information, being transparent with what we are looking at. And just this morning, we've launched a new version which incorporates a resurgence monitor in it as well. So this resurgence monitor takes 2 of the key indicators that I've spoken about, the week-on-week percent changes, and it brings it into a more intuitive, more easy to understand, and easily accessible version. And this gets updated on a daily basis. If you look at today, for example, and we've just launched now, you can see that the week-on-week percent change in terms of positivity is already showing itself up, but it's not showing itself up in the week-on-week percent change in new cases. If we look at it in terms of the second wave, this is what we are technically looking for. We're looking for, all red bars, more than 20% increase in terms of new cases, both in terms of average positivity and in terms of new cases. Yeah, so this is fully available, and yeah, I encourage anybody that's interested in terms of exploring this further to go and check out the dashboard. Thanks so much, Bob.
Thanks, Ms. Amel. I was just on mute there. Thanks very much for that input. Really useful to see this real-time data, and thank you to you and your colleagues for the work that you're doing. Just people who want to access that dashboard, is it publicly available? At least some of the screens.
So yes, I mean, just to answer your question, so yes, 2 of the indicators we've made it completely publicly available as of today, actually. That really does allow us to be transparent and for everybody to know when we are actually entering a resurgence. Of course, the other indicators we haven't made public for a number of reasons, just in terms of the sensitivity of the data, the ability to interpret it, and the changes that happens that occurs with regards to increases and decreases. So we haven't made everything public, but certainly enough of it to be able to identify the resurgence.
And if I mean, there is a very definite signal that we're seeing an increase in at least in percentage positivity. But if I understand correctly, it hasn't met the threshold for a resurgence at 20%. And it hasn't met that threshold in any sub-district yet. Is that correct?
Yes, so that's correct. So we haven't actually seen a sustained, consistent increase in any particular sub-district above a 20% increase. Not as yet. It's certainly at alert, but not at resurgence.
Yeah. Okay. Thanks again, Ms. Amel, and hopefully we'll have you back on the webinar at some point. Really good to have your input. Thank you. So we're going to move on to our main speaker for today, and I'm very excited to introduce Professor John Eichelboom. John's going to speak to us on the issue of thrombosis in COVID-19, which we of course know is one of the key complications of this condition and key contributors to the pathogenesis of severe COVID-19. John is a professor in the Department of Medicine at McMaster University in Canada. He's a senior investigator at the Population Health Research Institute, or PHRI, and a hematologist at the Hamilton General Hospital in Ontario. John also holds the Jack Hirsch PHRI Chair in Thrombosis and Atherosclerosis, and his research focuses on novel approaches to preventing and treating thromboembolism and bleeding, and more recently focusing on randomized trials in COVID-19. around the issue of thrombosis. John has co-authored more than 675 articles in peer-reviewed journals, and since 2014 has been listed annually among the top 1% of most cited researchers worldwide. John has also collaborated with Professor Pat Comerford at UCT in Groote for many years in cardiovascular trials. And so it's a great privilege to introduce John this afternoon to present at our webinar on COVID-19, inflammation and thrombosis, a state of the science. So over to you, John, and really looking forward to your talk.
Well, thank you so much, Graham. It's really a pleasure and an honor to be invited to this mecca of infectious diseases, this powerhouse where you generate evidence for the world on infectious diseases. I also want to thank, well, yourself and Sean and Pat for inviting me to be here and for all the support I've received. I'm hoping to spend some time in South Africa on a sabbatical, and Gary Martins and Pico and CK have also been very supportive. So thank you all. I am somewhat of an imposter because I am a hematologist. And as you mentioned, I have spent most of my research career in cardiovascular medicine, not in infectious disease research. I'm somewhat heartened when looking at COVID-19 that this is perhaps, and I speak tongue in cheek, a disease of thrombosis masquerading as an infection, but more on that a little later on. And I have a number of disclosures, which I will not dwell on. I'd like to take the 25 or 30 minutes that you have allocated me to focus on two topics. The first topic is COVID-19 and thrombosis. And then in the second part of my presentation, I want to turn to this fascinating problem of vaccine-induced immune thrombotic thrombocytopenia, something that perhaps you have not seen too much of because the AstraZeneca and the Janssen vaccines are not being used in South Africa in any great amount, as I understand. But perhaps some of the other vaccines may also have this problem. Well, starting with COVID-19 and thrombosis. And I don't need to tell you about the manifestations of this disease. I thought the description, a syndrome of deregulated immunothrombosis, captures very nicely the pathogenesis of this disease. We see the viremia, we see inflammation and the endothelialopathy, which starts in the lung and then becomes systemic, and we see hypercoagulability, which is manifest clinically in many ways, but in particular venous thrombosis, less common arterial thrombosis, and at post-mortem microvascular thrombosis. And 80 or 90% of people who succumb to this illness will have evidence of thrombosis. Now, any effort to summarize the state of the science must acknowledge that that task is daunting. A quick search of PubMed as of 48 hours ago reveals that in 2020, there were more than 90,000 papers listed on PubMed, no less than 472 in the New England Journal of Medicine. And this year already, in the first 4 months, 50,000 papers. And the New England has gone to publish 155 papers, a really remarkable, indeed unprecedented situation. I'm going to pick out some of the pearls, some of the highlights that I think are of greatest relevance. Let me start with the stages of COVID-19. And you are all aware that we can divide this disease into pre-symptomatic and symptomatic, and then symptomatic, early, medium, and advanced disease, or stage 1, 2, 3, whatever way you would like to subcategorize them. What's important is that there is a progression from early stage to late stage in the extent of the viremia, in the extent of the inflammatory response, and of particular focus in this presentation, the extent to which coagulation is activated. And coagulation activation is reflected perhaps most sensitively by D-dimer levels. And I suspect you, as we do, routinely measure this in people with COVID, and we see progression in the level of D-dimer as the disease becomes more advanced. This is accompanied by changes in platelet count, by changes in the prothrombin time and fibrinogen, as well as inflammatory markers. Folks at our institution have published together with others on the topic of COVID-19 hypercoagulability and have described this natural progression from simply a D-dimer elevated to a COVID-19 associated coagulopathy, and finally culminating in progressively worse DIC. The mechanisms of disease. When I show this slide, you will immediately throw back your hands and say, how does this add value to this discussion? And I won't go through any of this in detail, but suffice it to say that if we carefully were to track through this slide, we would see a rational, a logical progression from the virus entering the cell through the ACE2 receptor, the monocyte identifying this viral entry, the monocyte exposing tissue factor, which activates coagulation, the monocyte NLRP3 inflammasome being activated and releasing cytokines, activation of neutrophils, the formation of neutrophil extracellular traps, driving contact-induced coagulation activation, inactivating natural anticoagulants, and activating platelets, thereby leading to this intense hypercoagulability. If we look at the clinical manifestations, we see the dominant thrombotic manifestation is venous. And that's no surprise because clinically, this is most evident at the bedside. The next most common clinical manifestation of thrombosis is arterial thrombosis. But as mentioned earlier, it is the microvascular thrombosis that is probably the main driver of significant morbidity and mortality. And this is widespread, it's dominant in the lungs, but can affect any organ. If we consider this picture of hypercoagulability and thromboembolism, it seems almost intuitive that treating this disease with antithrombotic therapy is going to be effective in preventing thrombosis, in saving lives. Indeed, many people around the world have figured that this is so intuitive, it's so obvious that we can simply get on today and start treating people with prophylactic doses, that is with prophylaxis using prophylactic or intermediate or perhaps even therapeutic doses of anticoagulation. To date, we have very little in the way of definitive randomized trial evidence, and the evidence that we do have raises questions about the efficacy of using therapeutic anticoagulation in these patients, because it is unclear that it leads to meaningful benefits for patients. And I will review those data with you in some detail. Now, as I do so, I want to remind you, and this is a paper that we published in JACC recently on the currently ongoing antithrombotic trials in COVID-19. There are no less than 70 odd trials that are currently ongoing, and they span the outpatient, the inpatient, ward COVID-19 patient, the critically ill patient, and the post-discharge patient. And they include heparin-based regimens, direct oral anticoagulants, antiplatelet drugs, and fibrinolytic therapies. Despite this large number of trials, to date, we have only 2 or 3 published randomized trials. Now, I expect that the NIH multi-platform trial, which is the largest trial completed to date, should publish in the next week or 2. Indeed, every day I go to my Google search and say, is this trial published yet? Because we haven't yet seen the data. But I will show you the interim data from this trial. Last week, one of our hematologists, who was a member of the steering committee of one of the 3 trials that comprise this multi-platform trial, went to our formulary folk in the hospital and said, based on these data, we should routinely use therapeutic anticoagulation in the hospitalized COVID-19 patient. More on that in a moment. This multi-platform trial randomized adult patients with COVID-19 within 72 hours of admission. They received either therapeutic heparin or prophylactic anticoagulation for 14 days or until discharge. The primary outcome was a composite of days free of organ support or in-hospital mortality. And these days free of organ support and mortality outcomes were combined in a single composite as measured by a number. So deaths counted for a certain number of days of organ support. And this was weighted according to the importance of death. Somewhat arbitrary, but perfectly understandable. The analyses were stratified, and there were 2 strata. One was for moderate disease patients, and one was severe disease patients. In the moderate stratum, there were 3 separate strata, those with high D-dimer, those with low D-dimer, and those with no D-dimer. The interim results are shown here. Now, by way of explanation, we've divided this into severe disease below the line, that's these 2 columns here, and moderate disease above the line. And there you have the 3 groups I've just mentioned: D-dimer measured and high, D-dimer measured and low, and D-dimer measured and missing. So if we take the severe disease patients first, this column here at the bottom is people on therapeutic anticoagulation. This column here is people on prophylactic anticoagulation. And the longer this red bar, the worse the patient did. And this red bar reflects a combination of death and days of organ support. The blue reflects days free of organ support. So in severe disease, just eyeballing the colors, therapeutic anticoagulation does worse than prophylaxis. In the moderate disease, the pattern is reversed. The event rates are much lower, understandably, because they're not critically ill. But in each case, the column for prophylaxis is slightly longer than the column for therapeutics. This result would suggest that in moderate disease patients, therapeutic anticoagulation is better than prophylaxis. In severe patients, therapeutic anticoagulation is worse than prophylaxis. A little more on the details of the study, and these are interim data. I expect the numbers will all change when the final paper comes out, and it's rumored that this is with a major journal and should appear very soon. So if we take the moderate patients and we look at thrombotic events, we reduce the event rate from 5.3% to 1.9%. Looks like a very nice treatment effect. If we look at the moderate state mortality, this is paralleled by a 2% lower rate of mortality. This is 14 events, and this is 8 events. In the severe state, we also get a reduction in thrombosis, and the thrombus event rate is higher in the control group. There is a substantial reduction in absolute terms, greater than in the moderate state, as one might expect. But in contrast to moderate patients, in the severe state, the mortality goes the wrong way by about 16 events. In both moderate and severe disease, bleeding is increased. So how to interpret these data? One, it's possible that this is the truth, that anticoagulants work when you're not very sick or you're less sick, and they're harmful when you're really sick. We have to think of a hypothesis that explains that. For example, maybe in the really sick people, you miss the boat, but you wouldn't expect harm unless bleeding's causing harm. Why then, if you reduce thrombosis in the sick people, don't you see a benefit? It's possible that this is just the play of chance. You see a bit of benefit here and a bit of harm there, but you take the totality of the evidence, the effect is neutral. I would put to you that we simply don't know the answer to that. Is there any external evidence that can inform this? Well, not really at the moment. We do have the Inspiration trial, a much smaller study, about 600 people, published in JAMA recently, and there is a follow-up just published online in Thrombosis and Hemostasis. This was confined to critical disease patients, and it suggested that intermediate dose heparin, given as enoxaparin, was no better than standard prophylactic heparin. Of course, only in the critically ill patients, and it would be consistent with the NIH multi-platform trial, but doesn't really inform the field much further. What did the guidelines say? Well, here are the most recent guidelines from 2020 for 3 very prominent groups, and then 2021, these 4 guidelines were all issued after the availability, at least, of some of the NIH multi-platform trial results. You will notice that for hospitalized patients not in critical care, every guideline other than the most recent, the NIH CE guideline, which is driven by the NIH, recommends therapeutic prophylaxis, all the rest routine prophylaxis. In critical care, 4 of the 7 suggest increased intensity of prophylaxis, but not routine prophylaxis. Is this evidence-based? I think we could argue about this. These guidelines are out of date the moment they appear in print. They're based on expert opinion in part, on evidence in part, but I'd suggest to you many questions are left unanswered. To summarize, where are we in May 2021 for therapies in COVID-19? Well, we know that glucocorticoids work. We know that IL-6 receptor antagonists work. We think that remdesivir might work, that high titer convalescent plasma might work, that colchicine might work, although the recovery trial suggests otherwise, and that anticoagulation might work. I think there is a compelling rationale to continue to test at least the bottom 3 treatments in the probable group. We are currently doing the ACT trial, the anti-coronavirus therapy trial. In fact, it's 2 trials in inpatients and outpatients. It's a factorial design where we're comparing in the same patient either colchicine versus control or antithrombotic therapy versus control in inpatients and in outpatients. And we're very excited to have you on board as one of the collaborators on this trial. Now, as I say that, I'm reminded by the philosophy that Bongani Mayosi always communicated with us, that there are many places where PHRI might go and say, we'd like you to help on a trial. We get the data and we walk out with the results. I'm hoping that PHRI has a different philosophy and that we like to contribute to the countries where we actually do the trials. Certainly, one of our goals in COVID-19 research is to ensure that the results of the trial benefit the places where we do the trial. But to do that, we do need to get a sufficient number of people in South Africa so that the results can be generalized in the local environment. In the second part of my presentation, in the next 8 or 9 minutes, I want to turn my attention to vaccine-induced immune thrombocytopenia. It's remarkable that 2 months ago, had I mentioned this, I wouldn't have, because I would not have been aware. All of you would have given me probably a blank stare, except perhaps some of you are in advanced knowledge of emerging patterns. But in early March was the first time that VIT was recognized, and certainly it has had a major impact on people thinking about vaccination. We've had very large trials in a very short period of time. Much debate has been fueled by this recent report of VIT. I'm reminded last year in September when I spoke on COVID, I saw this in the New York Times, and I was informed by the writer that the usual pace of vaccine development would suggest that we would have a COVID-19 vaccine by 2033. Of course, this entire process has been compressed, and the New York Times suggested that we were targeting August 2021 as a release for the vaccine. This was achieved close to 3/4 of a year earlier than anticipated. But of course, the price we pay is the unexpected. And on April 9, the first report came out in the New England Journal of Medicine of VIT, or thrombotic thrombocytopenia, after the AstraZeneca Oxford vaccine. That same day, there was a second report, a brief report on this topic. On April 14, there was a third report, correspondence with thrombosis. Then there was a further report on April 16. This was with the Janssen vaccine. There was a fourth report on April 16, and this was accompanied by an editorial. 5 papers in the New England Journal of Medicine within 8 weeks of reporting of VIT. Now, what is VIT? We know from the 3 reports in the New England Journal of Medicine, about 39 patients, that it occurred in the days following exposure to vaccine, mainly in younger people, predominantly in women, and was characterized by a reduction in platelet count, usually between 20 and 50, and was accompanied by a positive ELISA test for the HIT type antibody. So here are the highlights, recognized very recently. The frequency, very broad-ranging reports. Probably the best estimate is about 1 in 100,000, but this is confounded by biases in ascertainment and reporting. The first presentation of VIT is invariably thrombosis. When such patients are investigated, they are invariably found to have a reduction in platelet count. And the early data suggested a 40% mortality rate. That mortality is probably coming down now that we know how to recognize and treat the disease. So the typical presentation, who? It's a younger patient, more often a female than a male, but we've had our first case at the Hamilton General Hospital in a 69-year-old man. When do they present? 4 to 30 days post-vaccination. The first or sometimes a second dose of a vaccine that is based on the adenovirus vector. And that is the AZ vaccine, the Janssen vaccine. I don't know about the Russian vaccine, but that's also an adenovirus vaccine. I don't know about the CanSino vaccine. So far, to my knowledge, there are no reports of VIT with an mRNA vaccine or a protein-based vaccine. And I see a paper in the New England Journal of Medicine this week on a trial with one of these vaccines in South Africa. How do people present? Thrombosis in unusual locations, particularly cerebral venous sinus thrombosis, but also splanchnic thrombosis. You can get PE or arterial thrombosis. Our case at the Hamilton General had cerebral venous sinus thrombosis, portal vein thrombosis, and pulmonary embolism. What symptoms are present on presentation? Well, it's the symptoms of cerebral venous sinus thrombosis, of pulmonary embolism, of intra-abdominal thrombosis, or of deep vein thrombosis. What do we find in the laboratory? The platelet count is always reduced. It's usually between 20 and 50. In the cases that I'm aware of to date, the highest platelet count was 113. When we do the test for HIT, we start normally with a screening test using either an ELISA assay or a rapid immunoassay. In patients with VIT, the ELISA is almost always strongly positive with a very high optical density reading. The rapid immunoassay is likely much less sensitive, and therefore you cannot rule out this disease with an immunoassay. So please, if you are screening for this, then use an ELISA. The confirmatory test is with a positive platelet activation assay. A serotonin release assay is what we use here in Canada. I will tell you a little bit more about that in a moment. And these people look exactly like a HIT case, except the exposure is not heparin, the exposure is the vaccine. We know there's a high early mortality data. We think more realistically, it's in the order of 20%. It may be lower if appropriate treatment is instituted promptly. Here is our flow diagram for workup, and this is published by one of our hematologists who works on the council in Canada to develop approaches to VIT. My slides have a lot of links on them. Anybody who would like my slides, if you need the references, you can click on them, and I'm happy for my slides to be disseminated to anybody who would like them, if they happen to be useful. So this is the flow diagram. I've been through the details, and in the interest of time, I will move on, but we find this a useful flow diagram to work through a patient with suspected VIT. The treatment is almost identical to that for HIT. High dose intravenous immunoglobulins given at a dose of 1 gram per kilogram daily for 2 days. This blocks the interaction between the VIT antibody, which binds to platelet factor 4, and a polyanion, which we believe comes somehow from that adenovirus. So the adenovirus vector interacts with the PF4. That complex is bound by an antibody, and the FC portion of that antibody binds to the FC receptor on a platelet, and this results in platelet activation. If we give IVIG, we block this interaction between the antibody and the platelet, and thereby we prevent platelet activation, and there is a prompt rise in platelet count. We avoid the use of heparin, although it is interesting that in the confirmatory platelet activation assay, heparin does not enhance the activation of platelets, and it seems very likely that heparin is an acceptable treatment, given that we have alternatives to heparin, and given the similarities to HIT, the recommendations around the world have been not to use heparin, but rather to use an indirect or a direct factor Xa inhibitor, a factor 2 inhibitor, or dinapride. The other recommendations are to avoid platelets because they can so-called fuel the fire, and to avoid warfarin because this can result in microthrombosis in patients with DIC due to warfarin's effect on protein C. The mechanisms of VIT, here is platelet factor 4. It complexes with a polyanion from the adenovirus. The VIT antibody binds this complex. This FC part of the antibody binds to the platelet. Plates are activated, aggregate, and cause thrombosis, which is microvascular and macrovascular thrombosis. The bottom line is, if you're exposed to a vaccine, if you have thrombosis and you present with, you also have thrombocytopenia, think VIT. Here is classical HIT. Heparin binds to platelet factor 4, and you see this complex heparin platelet factor 4 induces antibody formation, which activates the platelet. Here we have autoimmune HIT, which occurs in the absence of heparin. And this is probably the closest parallel to VIT. So no heparin. Instead, the role of heparin is taken by the adenovirus. The differential diagnosis of thrombotic thrombocytopenia, of course, includes a short list of other devastating illnesses. HIT is the top of the list, but there are thrombotic microangiopathies such as TTP or atypical HUS, or antiphospholipid antibody syndrome, or paroxysmal nocturnal hemoglobinuria, or cancer with thrombosis in patients with DIC. I will leave you with the VIT algorithm. If you forget everything else I've told you, if you're thinking VIT, you may think HIT with the 4T score, that is thrombosis, thrombocytopenia, timing, and no other diagnosis. Well, VIT is exactly like this. It's vaccine, it's interval, it's thrombosis and thrombocytopenia. Where does this leave us with the use of adenovirus-based vaccines? In Canada, the guidance is to continue using the AZ vaccine, to avoid it only in people with a history of HIT, people with a history of cerebral venous sinus thrombosis, in younger patients under the age of 30, partly because they're more prone to getting VIT, but partly because their individual benefits of being vaccinated are lower than the rest of the population because they have a low risk of complications, and therefore the risk-benefit ratio may be unfavorable and they should be preferred for an mRNA vaccine. And finally, pregnancy, because COVID is more severe in people with pregnancy, the mRNA vaccine is recommended. So I'm going to end there, Graham. Let me summarize. I've talked to you a little bit about COVID-19 and thrombosis. It's a scientifically a fascinating and remarkable illness. From a humanity perspective, it's clearly a devastating cause of morbidity and mortality. Lots of thrombosis. I'm not sure that we've solved the thrombosis story in COVID-19. I'm not even sure that we are benefiting our patients in any way with our current regimens. I've also talked to you about VIT, one of the rare but devastating complications of COVID-19 vaccines. Thank you very much for your attention.
Thanks very much, John, for that fantastic overview, both of thrombosis and COVID, and then this a new issue of VIT. And I think that there are a lot of really important take-home messages from your talk. So we've got time for questions and discussions. And I just wanted to start off by asking you the first question, really about the pathogenesis of thrombosis in COVID. And, you know, you've told us about how the immune response in the context of this viral infection, drives the thrombotic cascade. But with many other infections, we obviously see similar levels of immune activation and inflammation, and in some even to a greater extent. And what do you think it is specifically about SARS-CoV-2 that results in it having such a thrombotic tendency compared to other infections? Obviously, we see some similar things in other infections, but the degree and the frequency with which you see it in COVID seems far greater.
Well, Graham, to be honest, that's why I hope to spend some time in South Africa, because I don't know if there were ever better brains on this topic. They would probably be found in your town. We really don't know why the COVID-19 virus, why the SARS-CoV-2 virus results in such a florid immune response, and in turn, why that translates into such rampant hypercoagulability. Also, why do some people get this response but not others? Is that genetically driven? Why is it that people with comorbidities have such a higher rate of mortality? Is that because they have some susceptibility to this virus becoming rampant? Is it because they have less reserve to withstand the viral infection? There are so many unanswered questions. I simply don't know. I suspect that this cytokine storm is the driver of the thrombosis, and that we need to look for answers in the cytokine storm and why people with COVID-19 have such an intense immune response, rather than looking primarily at the thrombotic manifestations thereof. In part, the reason why antithrombotic therapy has not worked, I think, and why it probably won't work, I dare say, is that it's simply a downstream manifestation of the cytokine storm.
John, I'm going to open it up to further questions. I think just to say to people, if there are questions, to please post them in the chat function. But I wondered whether Sean Wasserman, who's an infectious diseases physician at Groote Schuur and has been working with John on the ACT trial and preparing for the ACT trial, if Sean wanted to come in and has any discussion points or questions.
Thanks, Graham. Hi, John. It was a wonderful talk. Just to say that paradoxically, as an infectious diseases physician, I actually feel like an imposter with this condition. We last year were confronted with this disease where we just saw frequent and widespread thrombosis and respiratory failure, and it didn't feel like a kind of infection, an infectious disease that we see at all. And I mean, I think you discussed this and brought this out very clearly early on in your talk, this real difficulty thinking about how to kind of deal with this therapeutically. And in our minds, this is a little bit, or in my mind, this was different to thinking about the other repurposed agents for COVID, where we, from the beginning, took a very strong and explicit position that we were just going to follow high quality evidence for implementing these repurposed drugs, kind of directed at COVID, or even the consequences, the inflammatory consequences of COVID. This was a bit different. I mean, we saw clearly that that thrombosis was more frequent in our patients compared to other similarly severe conditions in the ICU. The post-mortem studies showed that microthrombosis, as you explained, was a massive problem and probably a contributor to respiratory failure. And we had very few other treatment options, just like we have now in our country. It's just steroids. And you know, treating thrombosis and hypercoagulation is a complication of this, and it's a standard treatment that we used for these kinds of complications. And so we thought about it a little bit differently, and we're very aggressive in our approach to thinking about using anticoagulation. So all patients who needed oxygen got intermediate dose heparin or low molecular weight heparin, And those that were more severely ill received therapeutic heparin in our kind of in our guidelines, in our local guidelines. And this was based on thinking that a venous thromboembolism is difficult to diagnose and is common, and we might as well just treat it. I think you've also explained very clearly that the state of equipoise still exists, given the confusing and conflicting results we find from these preliminary data from the multi-platform trials and even the inspiration trial, where half of those patients actually didn't require high flow oxygen, even though they were in ICU. And so I think this leaves us with equipoise, and I think this opens the door to and requires us doing more randomized controlled trials. And I'm very excited to give our patients the opportunity to participate in the ACT trial when it gets going. But I wanted to ask you, given that thrombosis is a problem, that we have this treatment for thrombosis in other contexts, in your center, how do you manage thinking about this and explaining to clinicians that there is equipoise, that we should go with guideline recommendations using standard prophylaxis, and kind of holding out for higher quality evidence, which is, I think, what we're grappling with. Thanks very much.
Terrific. Thanks very much, Sean. Great to hear you. Yeah, I think you've summarized it beautifully. I remind clinicians when we think about the thrombotic problem of something that no one wants to hear. And no one wants to hear what was published in Lancet Hematology last year, a meta-analysis of every trial done in the last 20 years of venous thrombosis prevention, that in trials where venous thrombosis was reduced, there was absolutely no mortality benefit, because each and every one of us wants to believe that stopping venous thrombosis saves lives. And I'm going out on a limb here and being radical, but remember that in cancer, remember the seminal trials of venous thrombosis in cancer, the CLOT trial 2003, New England Journal of Medicine, there's a 50% reduction in thrombosis. The effect on mortality, nil. Remember trials of venous thrombosis prevention, long-term in venous thrombosis. If you go beyond 3 to 6 months, we all treat these people. If you look at those trials in aggregate and you prevent thrombosis, the effect on mortality, zero. So I think our thinking needs to change. We want to prevent thrombosis. Sure, it's a cause of mortality, morbidity, and rarely I say mortality. People with venous thrombosis die, but preventing venous thrombosis doesn't save lives because it is an end result of another pathology. So my message to people treating COVID is use prophylaxis in everybody. If you can randomize, then randomize, because we need new data. If you can't randomize, do what's best for your patient. Sometimes you'll go out on a limb and give them therapeutic anticoagulation. Sometimes you won't. But remember that we simply don't know that it will save lives.
If I can just add a comment there that, I think, as Sean was summarizing our approach to this condition, first witnessing it, hearing the reports around the world, and then coming up with a guideline, it's been such an important lesson that we've learned that we need to kind of always relearn is that what we think that we're doing to sort of help a situation clinically with a management approach based on our sound rationale and arguments always needs to be subjected to randomized trials, because we might think that we're doing benefit and we might well not be doing any benefit and might be doing harm. And I think it's just, a generic lesson that we've learned from this issue in the context of COVID. I'm going to go over to the chat function now and ask Mark Sundrup if there are any questions that he wants to pose from the chat. Or is it Wendy?
So maybe I can just start. There's a question from Linda Gill Becker saying how sure we are that this is due to adenovirus, the thromboembolic events. Are we absolutely sure it's the adenovirus? And then there'll be a few more questions in terms of therapeutics, but maybe start with the adenovirus questions.
Yeah, great question. And we can't be sure that it is the adenovirus. This is really a proposed mechanism that there's some polyanion. I don't know whether it's genetic material or something that combines with the platelet factor 4. And no hard evidence that this is so.
And then there's a question on the role of aspirin in prophylaxis for VIT. And then what do we do in individuals who are already on chronic warfarin? Does that reduce the risk, or is it a problem?
So aspirin, we simply don't know. One might hypothesize that given the prominence of microvascular thrombosis, that strategies that target the platelet might be of benefit. I think we need to do the randomized trials. There are a number of such trials ongoing. Ours is one of them in outpatients, but we simply don't know. If you can randomize, do it. If you can't, and you feel inclined to use aspirin, I'm not going to be critical of that. For people who are already anticoagulated, observational studies, of which there are far too many, causing far too much uncertainty, misleading many clinicians. The observational studies, you can choose the one you like to decide whether this is helpful, harmful, or neutral. We simply don't know. I tell my patients the best evidence is if you're on an anticoagulant and you get COVID, you stay on it because you still have an indication. But whether this helps such people or harms them or is neutral, we simply don't know.
And if somebody was on chronic warfarin, would you avoid the adenovirus-based vaccine if you had the option?
Absolutely not. I think the key message is we need to vaccinate, and we need to vaccinate everybody we can, and we need to vaccinate with the best available vaccine. And we should give patients clear and definitive advice to get on and vaccinate. I get asked this question 3 or 4 times per day. I've had my first question already today from patients who call in, and I say, if you can get the AZ vaccine and you meet the Canadian guidelines for it, please get on with it. There is no suggestion that being on an anticoagulant or having a history of thrombosis makes you more prone to this, what I would call idiosyncratic reaction to the AZ vaccine. The only exceptions we have is HITS, cerebral venous sinus thrombosis. That is purely, well, I won't call it speculation, it is expert opinion, but even that, avoiding it in those people is not based on any known mechanisms or evidence.
And then one of the other questions relates to the fact that under the age of 30, you don't recommend the adenovirus vaccines. How does that really affect countries who might only have that option?
Well, thank you for the question. And I put on my slide, this is a Canadian recommendation. It's a problem of a country that has a surplus, or at least has ordered a surplus of vaccines. I would say for any other country that doesn't have access to alternative vaccines, you should vaccinate with the vaccine that's available. And I would have no hesitation in recommending the AZ vaccine to younger people. This complication is rare, and unless we stop this virus, if we can, I'm not sure it's possible, but unless we stop this virus from circulating in the community and mutating, we're going to continually encounter variants that potentially could be resistant, so to speak, to vaccination.
John, if I can just add some context there from South Africa, is that we have been providing access to healthcare workers with the Johnson & Johnson vaccine through a phase 3B trial, but the government has now procured the Johnson & Johnson for the majority of the national rollout, with some Pfizer vaccine, but you know that 80 to 90% of our vaccination will be with Johnson & Johnson, and the risk seems to be lower with that, with the data that we have to date compared to the AZ vaccine.
And so, Graham, I suppose in South Africa, and it's a little naive of me to put up what I did put up, because if you have the the Johnson & Johnson vaccine, I'd say everybody should go for it without concern, even in the 20-year-olds and the pregnant patients. Probably everybody should just go for it.
Yeah, that's very much our advice. Yeah.
There's another question from Linda Gale Becker. The adenovirus-based vaccines are used in other settings. So do we think the problems relate to the combo with the spike in terms of thrombosis?
Well, wonderful questions that I really can't answer. We don't think that the spike protein has anything to do with the formation of antibodies to the platelet factor 4 hypothesized complex between platelet factor 4 and a polyanion. Certainly the studies that were done by Andreas Greinacher and with Ted Walkington from our place suggest that there's no involvement of the spike protein.
I've got a few more questions from Jeff DeShaker from London. Any role for danazol, which can be used in ITP for VIT? Do you have any experience or recommendations?
It brings back a blast from the past. These days, all I do is treat thrombosis and bleeding. But danazol, yes, we used to use it for ITP. I'm not aware of any evidence of a beneficial effect of danazol in COVID-19.
So there's just a question from Mark Blockman. In terms of we don't have don't have much choice in terms of our using the adenovirus. The mRNA viruses are going to be limited. And really then commenting on your strong view of pregnancy means a great deal of our population who will not be able to receive the vaccine. But from your comment now, we really should go for it and not be hesitant.
My apologies. That was out of context. I tried to put on the slide in Canada to try and convey our approach here. But my apologies for being misleading in any way. If you have the J&J vaccine, please, I would wholly endorse its use in young people, in women, in men, in under 30s, in people with a history of HIT, cerebral venous sinus thrombosis, or pregnancy or breastfeeding. So in all of those conditions, please vaccinate your population.
And do you think there's any role in restricting it to certain trimesters, or it doesn't really matter where in pregnancy we administer it? Or in the period?
I think there's a lot of expertise at this session, and I would hesitate to just pretend that I'm the authority on this. There is a paper in the New England just in the last week or two on, I think it's 30,000 odd patients with a pregnancy who got the vaccine. There is a certain sense of we should avoid it in the first trimester because of concerns about early pregnancy loss. Whether that's valid or not, I suppose no one wants to be linked with pregnancy loss, even if there's no causal relationship. So I think it would be reasonable to give it at any time during pregnancy, but some might advocate giving it in the second or third trimester.
And then there's a question from Vernon Lowe, head of hematology here. If anti-platelet factor 4 platelet activating antibodies are detected, what is the value of using the heparin-induced platelet activation assay compared to other functional assays?
Yes, so I think that there are various functional assays that can be used. The beauty of the HIT assay is that in the presence of low-dose heparin, you enhance platelet activation in a HIT assay. In the case of VIT, low-dose heparin almost invariably suppresses platelet activation. So it does give you insights that heparin is not playing a role. If you give high-dose heparin, it inhibits the reaction in both situations. So that's somewhat of a discriminating feature. Having said that, I think if a patient comes in with vaccine exposure in the right time interval, with thrombosis and with thrombocytopenia, you're almost there. And you could argue that you could treat on spec, you could treat with that information. it's nice to demonstrate the platelet factor 4 antibody. If you wanted to start treatment based on the clinical presentation and thrombocytopenia, please take your blood before you send off the PF4 testing, because if you already filled the patient up with IVIG, you might get a negative result on the ELISA or PF4 antibodies. But I don't think that it's critical in every jurisdiction to have a sophisticated platelet activation assay. In Canada, Hamilton is the reference laboratory, and I think it's the only laboratory that offers a serotonin release assay. I don't know the availability in your country of the various laboratory assays.
And then maybe last one from Vernon as well. IVIG is really, really expensive in our setting. How strong is the evidence for this in the setting, noting that evidence in HIT is not very expensive? So sort of a cost benefit in terms of it being extremely expensive here.
I have to be very cautious in my answer, because I'm sensitive to the fact that I can make statements here that are irrelevant there. It's not as though we have good randomized evidence, even in HIT, that giving IVIG is effective. However, the observational data are so strong, the signal is so strong that it's become standard practice, and it makes a biologic sense. The clinical experience is an immediate, prompt rise in platelet count in HIT, and a prompt rise in platelet count in VIT. So I'm trying to be cautious here. If it can be accessed, given the high mortality of VIT, I think it should be used once the diagnosis is established. Now, if it's not accessible, then I think aggressive anticoagulation, together with avoiding platelets and withholding vitamin K antagonists until at least the platelet count's back to normal, would be the preferred treatment strategies.
I think there's just one last question, also from Vernon Lowe. In HIT patients, they can have a significant drop in the platelet count, but still within a normal range. And then are we, as a result of this, missing some VIT cases by insisting on a significant drop in platelets? So if you have a 50% drop in platelet count from 350 to 150, would this be pointed to VIT as well?
So in HIT, certainly going from 350 to 150 meets the criteria on the 4T score for a platelet count drop that would start me to think about HIT. Remembering that the 350, of course, has to be the patient's baseline. So we often see this in post-cardiac surgery, that platelet counts have a nadir at day 2 to 3, then they go up and then they come back down. And when they come back down, one has to calculate carefully the 50% reduction. But in HIT, that's fairly clear-cut. In VIT, we're really based on a case series of, 150 cases or so. I'm not aware of any cases of VIT that have been diagnosed in people with a normal platelet count. That's perhaps not that reassuring in terms of high quality evidence, but the current state of the knowledge is you need to have a platelet count that is below the lower limit of the reference range.
Graham, I think we've come to all the questions.
Great, thanks Wendy for posing the questions. And so just to end off, to say a big thank you to John again for a really stimulating discussion, excellent talk, and we're really looking forward to hosting you in Cape Town during your sabbatical to engage further on these issues around thrombosis and COVID, but thrombosis and other infectious diseases as well. So thanks to all the colleagues who attended the webinar this afternoon and for the engaging discussion in the chat. And we will be hosting our next webinar in early June, and we'll send out an advert in about 3 weeks' time about that. Thanks very much.
Thank you so much. Thank you.
Thanks.
Bye-bye.